Hello friends, I am Dr. Nikita Pahwa. Today, for my first video, I have chosen one of the most confusing but important topics in gynecology, that is etiology and pathophysiology of polycystic ovarian syndrome. Friends, polycystic ovarian syndrome is considered to be a complex trait arising from the interaction of genetic and environmental factors, usually first presenting when mature gonadotropin levels are achieved at puberty. The pathogenesis of PCOS can be envisioned according to a two-hit hypothesis, whereby the disorder arises as a congenitally programmed predisposition, which you can call as the first hit, that becomes manifest in the presence of a provocative factor, that is the second hit. The congenital factors can be either hereditary, that is genetic, or acquired, for example maternal androgens or nutritional factors affecting the fetus. The postnatal provocative factor usually is insulin resistance with compensatory hyperinsulinism, which may have been congenitally programmed or acquired postnatally due to simple exogenous obesity. So friends, first let us study the heritable traits and gene variants. First is maternal PCOS. Maternal PCOS is a risk factor in 25% of PCOS patients. Second is PCO morphology, which is inherited as autosomal dominant, hyperandrogenism, metabolic syndrome, some genetic mutations, McCune-Albright syndrome, which is high prevalence of PCOS, and epigenetic changes. The other factor is intrauterine environment. Insults to the intrauterine environment induce persistent changes in the developing embryogenic and fetal epigenome that leads to altered gene expression and disease in later life. Congenital virilization. Congenital adrenal hyperplasia in adolescents has high prevalence of PCOS. Now friends, androgens induce epigenetic changes both pre and postnatally. Fourth is disturbed fetal nutrition. Good evidence suggests that fetal undernutrition predisposes to metabolic syndrome and related CVS disease in the adulthood. Now these were the already existing pre-existing factors which we called as the first hit. Now second hit in which presence the first hit establishes itself, that is postnatal environment. Most commonly the all states of severe insulin resistance, and secondly sometimes hyperandrogenism like congenital adrenal hyperplasia and premature adrenarche. Now friends, what you need to know is that this is a simple, unified, minimal model of polycystic ovary syndrome pathophysiology. Friends, to make it easy, I have summarized it into 5 steps. Now let me tell you the first step. Friends, what you need to remember is that functional ovarian hyperandrogenism. Functional ovarian hyperandrogenism in the theca cells is nearly universal in PCOS, and it accounts for all the cardinal clinical features of the syndrome like oligoanovulation, PCO morphology and hirsutism. First step. Second step is that approximately half of the patients, not all, they have an abnormal degree of insulin resistant hyperinsulinism. As you can see in the second picture, insulin resistant hyperinsulinism. Now what does this do? This insulinism acts on theca cells to aggravate hyperandrogenism, which further synergizes with androgen to prematurely luteinize the granulosa cells and stimulates fat accumulation. See in this picture, insulin resistant hyperinsulinism acts on the theca cells to aggravate the functional ovarian hyperandrogenism, which further causes anovulation, PCO morphology and features like hirsutism. Third step is that the hyperandrogenemia which was created, it provokes LH axis. Now this LH axis acts on both the theca and the luteinized granulosa cells to worsen the hyperandrogenism. LH axis further acts on theca and further acts on granulosa cells to aggravate their actions. Fourth step is that LH also stimulates the luteinized granulosa cells to secrete estradiol. Now this estradiol further with the feedback mechanism suppresses FSH. So the classical feature which we know from very old times that there is LH axis and FSH deficiency. So this is the mechanism behind that. Now friends, the fifth step is that these hyperinsulinism initiated changes in the granulosa cells function further exacerbate PCOM and further hinder ovulation. The fifth is that obesity increases insulin resistance which further aggravates hyperandrogenism. See, in this figure, as you can see that the fifth step is that obesity causes insulin resistance and insulin resistance further leads to obesity. So these are primarily the 5 steps. Friends, how does all this happen? Let us study its mechanism. First is the mechanism of functional ovarian hyperandrogenism. How does ovarian hyperandrogenism occurs? So we know that there are two cells in the ovary, that is theca cell and granulosa cells. First, there is intrinsic dysregulation of the theca cell steroidogenesis. Why? Because there is a flaw in the downregulation of thecal androgen production. There are two mechanisms going on inside the theca cell, that is upregulation of LH receptors and downregulation of LH receptors, which are managed well. But in PCOS, because of some factors, there is a flaw in downregulation. So there is excessive androgen production. Similarly, there is a granulosa cell dysfunction caused by the androgens. Why? Now there are two mechanisms, normal mechanism which androgens does in the ovary. Androgens normally stimulate the transformation of primordial follicles into primary follicles. That is their recruitment, which is the first step in their growth and development into small antral follicles. Second, androgens normally synergize with FSH to induce LH receptor expression on the granulosa cells to form progesterone in response to LH and begins the formation of pre-ovulatory follicle. Now, since we have excess androgens, intraovarian, what does these excessive androgens do? They stimulate excessive number of small follicles to grow, which is responsible for increased AMH levels, which AMH is a product of the granulosa cells of small follicles. And second, there is premature luteinization of the follicle, that is granulosa cells luteinization occurs in the mid rather than the late follicular phase, which seems to be the basis for the follicular maturation arrest that hinders the emergence of a dominant follicle and precludes ovulation. So friends, these two steps, that is the increased proliferation of luteinized small follicles plus maturation arrest before the large antral follicular stage of follicular development, manifests as PCO morphology, which we commonly see on ultrasound. Now friends, this was intrinsic functional ovarian hyperandrogenism. Now as we know that in half of the cases there is insulin resistance in PCOS. Now how does insulin resistance cause PCOS? Insulin and LH, they act synergistically to stimulate androgen production. Peripheral insulin resistance leads to increased glucose, which acts on pancreas to form increased insulin. Now this insulin acts on the ovarian theca cells to produce excessive androgen production. This increased androgen acts on the liver, which leads to decreased sex hormone binding globulin. Due to decreased sex hormone binding globulin, there are further free androgens which further lead to peripheral insulin resistance. So there is a self-propagating positive feedback loop. Now, what does insulin resistance actually do? Insulin resistance only plays a primary pathogenic role in the development of PCOS in patients with severe or extreme insulin resistant syndromes. This is a major extra ovarian factor. Why is it remarkable? Because resistance to the metabolic effects of insulin is tissue specific. While skeletal muscle is resistant to insulin action on glucose metabolism due to mitochondrial associated gene dysfunction, the compensatory hyperinsulinemia elicits excess insulin action in ovary, liver, and adipocytes. What happens with this? The signaling pathways mediating mitogenic growth factor like protein anabolic and lipogenic actions of insulin, they remain sensitive to insulin. So these actions of insulin aggravate the steroidogenic dysregulation and contribute to obesity and acanthosis nigricans that are common comorbidities of PCOS. Aggravating factor in PCOS pathogenesis because it promotes functional ovarian hyperandrogenism. What does insulin sensitivity do? Hyperinsulinemia do? It sensitizes the intrinsically already which are dysregulated ovarian theca cells to secrete excess androgen in response to LH. Now, what does obesity do? In PCOS, visceral fat contributes more to insulin resistance than does subcutaneous fat because of enhanced lipolytic response to catecholamines. Now, lipolysis promotes insulin resistance. Why? Because there is a deficiency of insulin sensitizing adipokines and there is increased pro-inflammatory cytokines such as TNF alpha, which is secreted by adipose tissues. Now, these inflammatory cytokines cause insulin resistance and aggravate ovarian hyperandrogenism. And this hyperandrogenism further sensitizes the circulating mononuclear cells to secrete inflammatory cytokines. So this becomes a vicious cycle which aggravates hyperandrogenism and insulin resistance. Obesity sometimes is a sole cause. Why? Because both androgen and estrogen are formed in excess by adipose tissue of obese women. Now friends, there is another cause, that is functional adrenal hyperandrogenism. In 25 to 50% of the cases of primary functional ovarian hyperandrogenism, it is accompanied by related functional adrenal hyperandrogenism. And in another 5% of the cases, functional adrenal hyperandrogenism is the only detectable source of androgen excess. Now, these type of PCOS are uncommon. The most common are associated with only ovarian hyperandrogenism, but some, like 25% of them, are accompanied by adrenal hyperandrogenism. Now, how to differentiate between other causes of hyperandrogenemia, we will see in the next video. Thank you friends. If you have any doubt, please write me in the comment section and please give your feedback. Thank you.